Thank you, everyone, and thanks for this opportunity, and I'll get started. If you have any questions, please definitely, unmute yourself. I can't necessarily see the chat, but you guys can definitely unmute yourself and ask questions. Okay, can everybody see that okay? And hear me okay? Yes. Okay, let me just see. Okay. Perfect. I'll keep the chat down here just in case there's anything. So you guys can all see, okay, then we'll get started. So I'm Dr. Becker, and today I'm going to cover many things. Let me just get to my first slide. Talking about women and epilepsy, pregnancy, and beyond. We're going to talk about hormones and the menstrual cycle abnormalities, sexuality, contraception, pregnancy and fetal outcomes, breastfeeding, menopause, and bone health. So to get started, we're going to talk about epilepsy and the menstrual cycle. So many women have an association between their menstrual cycles and their seizures. And seizures often peak near ovulation or near your menstrual cycle. And I'll give you a graph to kind of explain that to you. High levels of estrogen are actually associated with increased seizure activity, and high levels of progesterone are associated with decreased seizure activity. So what we think about is E for estrogen and E for exacerbation or worsening of seizures, and P for protection, or P for progesterone and P for protection, basically, which leads to decreased seizure activity. High levels of estrogen may also lower other levels of some anti-epileptic drugs, such as lamictal or lamotrigine. So this is just a little graph to kind of help you guys understand that, although many of you probably experience this clinically. So, but basically what happens is you have the estradiol, which is estrogen, and progesterone. So right at ovulation, that estrogen is high. And as I said, seizures can be worse because estrogen is high. So you can get seizures at ovulation, or right when you're about to menstruate, the estrogen's not that high, but the progesterone falls. And I said that progesterone was protective. So because it's falling, you're also susceptible to have seizures here. So most women will have seizures, as we said, kind of around ovulation or potentially around their menstrual cycle. And so just to kind of boil it down, estrogen may be proconvulsant. And the reason that is because when you have a seizure is too much excitation. So inhibition actually helps stop seizures. And when you have estrogen, it basically lessens your inhibition. So basically, it increases inhibition to try to help stop seizures, and it actually decreases excitation, again, to try to help with seizures. 30 to 50% of women have epileptic patterns that correspond to the menstrual cycle. So many women can have issues with seizures around their menstrual cycle. So how do we treat this? So we ask patients about catamenial seizures or seizures around their menstrual cycle. And the way we try to figure it out is we ask them to keep a seizure calendar. So a seizure calendar would record dates of menses and also when the patient or when you have your seizures. So what it will do is it'll help us figure out if there is a relationship. Sometimes these seizures around your menstrual cycle are difficult to control with anti-seizure medications. So anytime you see ASM, it means anti-seizure medications. Increasing doses of anti-seizure medications, both either before a menstrual cycle or during a menstrual cycle, may be beneficial. But sometimes what happens is it actually just moves your seizures to an unpredictable time. The other thing that people try is kind of a combined oral contraceptive pill that will have progesterone in it. And lastly, sometimes we'll try intermittent progesterone supplements as well to try to help manage some of these seizures. But usually it's not always very easy, and we try a bunch of different things to try to help. Sexuality in epilepsy. So many, up to 50% of patients with epilepsy, both men and women, have decreased sexual desire or performance. And a lot of times this is related to reduction in androgens or estrogen, so a reduction to hormones. And a lot of this reduction in hormones is partially related to the medications that you might be on. So it could be caused by medications alone or also metabolism interactions to medications. So sometimes some medications can increase the breakdown of other things in the body that would contribute to this. And so you can always switch medications. It may also, the patient may have low hormone levels, again, because of the medications they're on. A patient may also have anxiety or depression just from having epilepsy, whether the psychosocial effects of epilepsy or also the structural changes in the brain can also impact the mood pathways. Sometimes there's reduction in genital blood flow in response to erotic stimulation in patients, especially patients who are on medications called inducers, which means they, as I said before, break down other medications or other hormones in the body. And some of this can lead to erectile dysfunction, so erectile dysfunction medications do help. You can also have sexual dysfunction because of cosmetic concerns such as weight gain, excessive hair, side effects, things like that. Or just even concern about having a seizure during intercourse can affect your ability to have intercourse. And so the bottom line is that these things need to be spoken about with our patients. And I actually can see a question real quick. Can meds increase testosterone levels in females? So yes, they can basically probably increase or decrease depending on the medications you have. And so usually you want to talk with your doctors and or your urologist or gynecologist as well. Sometimes, it doesn't often increase testosterone, but I think it can happen. And so what we do is we'll get levels, or the urologist or OB will get levels and we'll work with them. Good questions. And I have the chat box up. So just kind of put a question and I'll keep my eye there and kind of answer it as we go along. I'll be answering questions at the end too. So don't feel like you have to write into the chat box, but in case you feel you might forget, just write it in. If there's a lot of questions, I'll put some of them towards the end, but if it's one here or there, I'll try to answer it as I'm talking to you. So anti-seizure medications and contraception. So contraception can be very challenging because many commonly used methods of birth control are actually less effective because they have hormones in them that the anti-seizure drugs can interact with. And so there's a high potential for interaction basically because both the seizure medications and the birth control medications utilize the same metabolism pathway. So what happens is birth control actually gets broken down faster than it should, and it's less effective. And women with epilepsy can have a large percentage of unplanned pregnancies compared to other patients with chronic disorders. So increased metabolism by some anti-seizure medications on the estradiol or the progesterone in the oral contraceptives can cause oral contraceptive failure. So a lot of times we may make recommendations for different contraceptions, and I'll give you that on the next page. So when you're talking about family planning with women taking anti-seizure medications, the specific drugs that can kind of interact with contraception are shown right here. So carbamazepine, oxcarb, phenytoin, phenobarb, primidone, Topamax at certain doses, so Topamax at greater than 200 per day can affect the efficacy of birth control. Lamictal is a little bit different. What happens with Lamictal is that oral contraceptives actually induce or break down Lamictal faster. So if you are on Lamictal and all of a sudden you start on a birth control pill, you may drastically lower your Lamictal level and be at risk for increased seizures. So I tell any of my patients on Lamictal, if they either start or stop birth control, they need to call me right away and I need to check a level and make sure that it's stable. And if it's not, change accordingly. There's been no reported interactions with benzodiazepines, gabapentin, levetiracetam, which is Keppra, pregabalin, valproate, or zonisamide. I said that we would talk about some other forms of birth control are available. Now, if you have intercourse and you're worried that you got pregnant and you weren't on birth control, you can use emergency contraceptive pill known as the morning after pill or the Plan B, but a lot of times you need to double the first dose again because some of the medications that you might be on may make this less effective. Some patients are on Depo Provera injections or intrauterine devices, so that's usually a recommendation that we'll use. Basically, you want to be on some sort of contraception that doesn't rely or interact solely with hormones. And so that's why the intrauterine devices or contraceptives like the Mirena as well are good choices. And you always can use alternative methods such as barrier devices, condoms, diaphragms, surgical cap as well. So now I'm going to move on a little bit to pregnancy and planning and pre, during, and post pregnancy management. So 1.5 million have epilepsy in the United States, and actually, or 4.3 million anti-seizure medications are written annually to these women. And you might think, well, that really doesn't add up, but there are a lot of patients who may not have epilepsy that are also on drugs that are considered anti-seizure medications for mood disorders, and also epilepsy as well. So there is a high exposure rate to these medications. So many questions that I have been asked, or many people with, many women with epilepsy may ask in planning pregnancy is, can I get pregnant? Or what is the best anti-seizure medication I should be on? Should I even be on an anti-seizure medication? And as I said, if so, which is the best? And seizure control. Will my seizures remain controlled, or they change during pregnancy, or they worsen? So the important thing is that you are not alone, that many, many women with epilepsy get pregnant and have healthy pregnancies and healthy babies. So women with epilepsy account for 1 in 200 pregnancies in the United States, and over 25,000 children are born to mothers with epilepsy each year in this country. 33% of women with epilepsy do not consider having children because of their epilepsy. And that is another reason why I make this kind of the hallmark of my talk, because many women don't think that they can have children because they haven't had the discussion, or because they may have been misled by discussions with previous physicians. So there have been several studies, study done by Dr. Jacqueline French and Paige Pinnell, looking at fertility in women with epilepsy, comparing it to women without epilepsy. And they found that there's a comparable likelihood of achieving pregnancy. So women with epilepsy are just as likely to achieve pregnancy. They have the same amount of time to achieve pregnancy, and they also have comparable pregnancy outcomes, looking at live births versus miscarriage, as patients without epilepsy. So what is the risk of having a child with a birth defect? So general population, the risk of congenital malformations or birth defects in the healthy population is about 1.6 to 3.2. Generally, the risk of developing a major birth defect or congenital malformation for women with epilepsy is increased about twofold. So it's anywhere from about 3 to 6%. But it's important to note that greater than 90% of women have routine pregnancies and healthy babies. So what are the general rules for birth defects? So using one medication is safer than using two or more medications. So ideally, we want patients to be on monotherapy, one medication if we can. If they are on polytherapy or more than one medication, we want them to be on the least dose that they need. So higher doses of medication are worse than lower doses. This all being said, it's a good idea to take medications while you are pregnant, because that can lead to worsened seizures, worsened side effects. And our main goal during pregnancy is to keep the mother seizure-free. There are individual differences amongst medications as well, so it's hard to know that someone will tolerate a new medication, and it's not something you really want to be doing almost a trial and error while someone is pregnant and could have a seizure, a breakthrough seizure. But there's growing evidence that shows that it's not only the type of anti-seizure medication, but also the amount of seizure medication that impacts the level of risk. So this is, again, just a kind of, a diagram to show you that the fetal malformations for women using anti-epileptic drugs is the highest in women on polytherapy, or, more than one medication. And you can see kind of general population and comparison. And major congenital malformations are actually seen the most with valproate. And we'll talk about that as well as I break some of the medications down. But if someone is on valproate or valproic acid, Depo, all the same drug, and they're planning pregnancy, that's usually when they'll have a discussion with their physician if if that's the only drug that ever worked for them, to try to get them on their lowest dose, or if they haven't been tried on other drugs, to potentially try to switch the drug before they get pregnant. So there's something called the North American Anti-Epileptic Drug Registry that has been around, I believe, since 1997. It's been around for over 20 years, and it has enrolled over 10,000 women who are pregnant on different anti-epileptic medications. And so you can see 1997 all the way up to, this was up until 2018, 2019, but obviously they're still recruiting. But the last publication was in October of 2019. But basically it shows the trend that more women are now on Lamictal, you can see in the green dots, and levetiracetam, which is Keppra. So lamotrigine is Lamictal. So on lamotrigine and levetiracetam, more women are now on those two medications. And you can see, a decrease in women on Topamax or topiramate because it's associated with cleft lip and cleft palate. You can see an increase, a slight increase in some of the other medications, but for the most part, levetiracetam and lamotrigine are the most recommended in a woman of childbearing age. And this is all published and information that you can get online if you even just Google North American AED Registry. And I have a page of resources at the end. But this shows, so for example, up until October of 2019, over 2,000 patients on lamotrigine were studied, and the risk of a congenital malformation was 2.3%. And I told you the general population is about 1.6 to 3%. So it falls, right in the general population. So maybe just a slight increased risk. Carbamazepine, you can see as well, has been studied and has a low risk, as well as levetiracetam. So we tend to use lamotrigine and levetiracetam the most. Carbamazepine is a good drug that is used, and so is oxcarb. You can see down here, oxcarbazepine, although there's lower numbers. But the problem with carbamazepine and oxcarbazepine is, I know I'd mentioned earlier about medications that can induce or break down, hormones or other medications like birth control. And carbamazepine and oxcarbazepine can also break down folic acid, which is needed to help prevent birth defects, and can also help improve IQ. And so, we tend to have our patients on folic acid, and I'll go through that a little bit further, but we'll have them on higher doses of folic acid if they're on something like carbamazepine or oxcarbazepine. So this is just a list of all of the medications that are, being studied, maybe in a future publication. And so you may see some of the medications that you are currently on in this list. So what kind of birth defects are seen? Well, birth defects can involve any organ system, but cleft lip and cleft palate, heart defects, and neural tube defects, or spina bifida, which is really associated with valproic acid, those are the most commonly seen. So at this point, really cleft lip and cleft palate seem to be the highest prevalence. But there are some other risks associated with anti-epileptic drugs. So lamotrigine, Topamax, and carbamazepine were increased with increased cleft lip and cleft palate. As I said, that's the most common. And some medications, including phenobarbital, phenytoin, and valproate, are also associated with a significant lower childhood IQ. So Depo exposed babies had a lower IQ than babies exposed to other medications, as you can see here. So, what is the chance of reduction in IQ? So this is basically a neurodevelopmental study that looked at women who are on certain medications, and outcomes with their pregnancy and their babies. And they found that, I really just highlight valproic acid, that there was a 13% risk of having a child with an IQ less than 70. And so lower IQ is linked with younger maternal age, absence of folic use or folic acid, which I had mentioned, lower socioeconomic status, and also higher doses of medication. Again, the study looked specifically at valproic acid, and it showed that the mean IQ score was about 9 points lower for children exposed to Depo greater than 800 a day, and that patients had an increased need for educational intervention. But doses less than 800 were thought to not necessarily reduce IQ, but there were still some reduced verbal ability. And so I told you, dose really plays a large role, and it's thought that if someone's on Depo 500 or less, it's thought to be much more safe for the mother and born fetus. Now, this is a study that actually just came out at the end of October in Neurology, and it's actually showing that there's an increased risk of autism spectrum disorder and ADHD in children born to mothers on valproic acid. So you can see I kind of quoted it. Maternal use of valproic acid, but not lamotrigine, is associated with an increased risk of autism spectrum disorder and attention deficit and hyperactivity disorder among children. And this is from a Swedish registry examining the risk of both the autism spectrum disorder and ADHD in over 14,000 patients from 1996 to 2011. So again, that's why I say if you are someone who is on Depo and is planning pregnancy, you really want to talk to your provider and see if that is the best medication for you. So I mentioned folic acid a couple different times. And so any woman of childbearing age, even if they're not currently pregnant, even if they're not planning pregnancy, we tend to put them on at least 1 milligram of folic acid, just in case there's any unplanned pregnancies, that it's protected. So it reduces the risk of neural tube defects and cleft lip and cleft palate. The required dose is unclear. Usually you see anywhere from 0.4 to 5 milligrams. As I said, if there's a drug that does not induce or break down folic acid, we'll keep patients on 1 milligram. If it is a drug that breaks down folic acid, as I mentioned, like carbamazepine or oxcarb or dilantin, we will put a patient actually on 4 or 5 milligrams of folic acid daily. And there's been some evidence that shows that taking folic acid before conception, is linked with higher IQ in babies. So this I put up here because a lot of times you may go and say, okay, what medication am I on? What's the risk? So the FDA used to categorize anti-seizure medications as category C or category D. And so category C, if you've heard of this in the past, talks about either studies in animals having revealed adverse effects on the fetus, but there's no controlled studies in women, and there's really no studies in women and animals, or studies in women and animals are not available. And you can see a list of medications here. But category D is positive evidence of human fetal risk, but the benefits from use of in pregnant women may be acceptable despite the risk. So D really is that they have evidence in humans that there are risks, and C is that they may have evidence in animals, but it really hasn't been studied in humans. But the problem is that it doesn't give a lot of information. It can be confusing, misleading. And so they changed the modifications to basically break it down into pregnancy, lactation, reproductive potential, talking about pregnancy exposure, and like the registry we just mentioned, showing, okay, if there are abnormalities seen, in human studies, what's the chance of them? What's like a risk summary? Again, the same thing for lactation and nursing mothers, and also just reproductive potential. So this new categorization helps make clinical and critical decisions, and gives a little bit more information to help mothers kind of determine, if they want or should breastfeed and things like that going through their pregnancy. So I mentioned this a little bit before, but single drug versus multi-drug, it's better to be on one drug at lower levels if possible. The risk of major malformations is, I said, 3 to 6 is really, or 2 to 7 for those on a single drug, but it increases exponentially up to 18% if you're on multiple medications, including valproic acid. But at the same time, having a generalized tonic-clonic seizure during pregnancy also can pose a lot of harm to the fetus. And so it's this fine line and fine balance, and that's why it's important to have a discussion with your providers. So if one anti-seizure medication does not control your seizures, it's better to be on 2 than to have seizures, because having seizures can pose a lot of risk to the unborn fetus. So if you, are on an anti-epileptic drug, women should only have those anti-epileptic or anti-seizure medications discontinued in preparation for pregnancy if. So as I said, there's pre-pregnancy planning, and you can talk to your provider. And so if you've been seizure-free for over 2 years, you can have that discussion of whether you need to, or you could possibly discontinue your medication or lower the doses. But you do have to accept the risk that there could be a seizure recurrence. And typically, if we're going to change medications, we ask that the woman wait at least 6 months for us to make sure that there's no adverse effects of taking them off the medication. Because the last thing we want you to do is get pregnant right away and not know and potentially have a seizure during the early stages of your pregnancy. But why not just stop? And so, and as I said before, if you stop the medications, or what the biggest risk is having seizures. And so what does that mean for pregnant women? What can that do to the baby? So it can lower fetal heart rate. It can cause premature delivery. It can cause low maternal and fetal oxygen levels. It can increase maternal and abdominal trauma. It can increase fetal death, and also can increase learning disabilities in patients. Seizure frequency change compared to pre-pregnancy. So there are studies that look and report that about 20 to 50%, but as high as 75% of women have seizure worsening during pregnancy compared to baseline. But it depends on several factors. And usually what we say is that, the control that you have, 9 to 12 months prior to conception is the control that you usually have through pregnancy. So it really depends on your baseline seizure frequency in the months prior. So ideally, you want to get your seizures under control prior to starting or planning conception. It also depends on the type of seizures you have. If you have focal seizures versus generalized seizures can sometimes be more traumatic to the unborn fetus. Anti-seizure medications, at the beginning of pregnancy, so what anti-seizure medications are they on, and how many seizure medications are they on? Are they on the ones that are, lower risk? Use of therapeutic drug monitoring. And a woman becomes pregnant, their volume of distribution, which basically means that drug levels can go down. And women also have an increased metabolism, so drug levels can go down. So you want to monitor the drug levels throughout the pregnancy and make sure that the dose itself of the medication doesn't need to be increased. Patient adherence also plays a huge role, and also stress, sleep deprivation, etc. So anti-seizure medication management before pregnancy. So if you do want to switch, we would choose to switch to another drug. If you want to do that, you may choose to switch to one that is more expected safety in pregnancy. But if you're going to do that, as I mentioned before, you want to do that well before conception, as the risk of birth defects is highest in that first trimester of pregnancy. So you want to change it much sooner and give yourself time to make sure that you tolerate the change. It's not always known how well a new seizure medication or anti-seizure medication will work, or if you could have side effects. So it's another reason to figure that out before you get pregnant. And changing to another anti-seizure medication during pregnancy does pose risk of multiple drug exposures, because typically we'll start you on a drug before we take you off the other drug, basically to make sure that you have covered protection. You can also have allergy and other serious side effects. So what is needed during pregnancy? So as I mentioned before, to have your blood levels checked routinely, especially because, as I said, you can have volume distribution increase and thus your blood levels can decrease over time during pregnancy. Continue taking folic acid and your prenatal vitamins. We recommend, someone with a history of epilepsy be referred to a high-risk OB and have an anatomic ultrasound at 11 and 13 weeks and 16 weeks, basically to look for any neural tube defects, heart defects, cleft lip, cleft palate. We also encourage our patients to register with the AED pregnancy registry. And this is the phone number, so that the more patients that we have in the registry, the more information we'll have to guide future pregnancies and really report any seizures promptly to your doctor. But what are the other important facts? And I mentioned some of this already. High levels of hormones can reduce drug levels during pregnancy. So as I said, you may need more frequent blood draws, and that there's a change in volume distribution. You can have malabsorption. And so the drugs can be eliminated more quickly, especially for lamotrigine. The metabolism can be increased to the point where you even have to double the dose. But many anti-epileptic drugs can cause the body to break down folic acid, which we had already mentioned. Specific ones, I mentioned carbamazepine, Dland, which is phenytoin, or valproate, which is valproic acid. And I'd already mentioned this, but those patients we would put on folic acid 4 milligrams to prevent neural tube defects and or other side effects or congenital malformations. And higher doses of folic acid may increase cognitive outcomes, as I mentioned previously as well. So what are some of the drugs that should be monitored throughout pregnancy? And so lamotrigine is definitely one that should be monitored monthly. And then carbamazepine, levetiracetam, and oxcarb, I usually monitor about once a trimester. If I do see it falling, then I will monitor it more often. And usually the anti-seizure medication doses are kind of increased systematically during pregnancy. After delivery, there is a need to reduce the anti-seizure medication doses rapidly to prevent toxicity, and that plan should be discussed prior to the patient delivering. So they know, the day after delivery or 2 days after delivery, we'll start reducing some of the medications that we may have increased during pregnancy. And we usually write you out a plan so that you know what to do, since you have a lot going on right after you have given birth to a baby. So delivery per se, so the American Academy of Neurology and the American Epilepsy Society have put guidelines out that show that there's no increased risk of cesarean delivery or late pregnancy bleeding for women with epilepsy. There's no increased risk of premature contractions or premature labor or delivery. Women taking anti-seizure medications are thought to have an increased risk of mild preeclampsia, possible gestational hypertension or high blood pressure, and may deliver before 34 weeks. Babies born to women taking anti-seizure meds can possibly have an increased risk of complications just after birth. So the bottom line of this slide is really hospital delivery is encouraged, just because you can't always predict, any risks that you may run into. So what about postpartum? So I mentioned that some medications are increased during pregnancy. So postpartum blood levels should also be checked closely, and levels usually return to pre-pregnancy values by 8 to 12 weeks after delivery for most medications. But as I said, you'll have a plan. You ideally should have a plan before you even deliver, knowing when you're going to reduce your medications. And then usually a week after delivery, your doctor will check a level, and depending on how high the dose increase was, they may check a couple different levels. And as I said, Lamictal or lamotrigine sometimes needs to be increased twofold. So the dose needs to be doubled. And so if that's the case, usually you'll half that dose a day or two after delivery. It's also important to try to avoid sleep deprivation, at least try. That's easier said than done. And we'll also discuss breastfeeding, but that's important to discuss with your patients as well, for us to discuss with you. So breastfeeding advantages: it reduces the risk of infant mortality, of infant infection, of infant autoimmune diseases. It's thought to improve cognitive outcomes in infants. It's also cheaper and potentially more nutritionally complete than formula. These are coming from recommendations from some of the society. It's thought that it possibly can provide some extra benefit to babies. However, with breastfeeding, there are some serum levels of anti-epileptic drugs in breastfeeding infants, but they're usually lower than what the infant would have seen throughout the pregnancy. So it's thought that it should not be significant. However, the infant should be monitored closely for side effects. And if there's any concern, if the infant becomes more fatigued, failure to thrive, not meeting milestones, things like that, a level can be checked at the pediatrician's office to make sure that there's no high levels in their system. And the drugs that seem to be the biggest offenders for this are phenobarbital, primidone, Ativan, Valium, ethosuximide, really a lot of the barbiturates or benzodiazepines. That should really be avoided when breastfeeding because of concerns for increased infant sedation. So motherhood safety and epilepsy. So it's important to take your medications despite changes in routine, rest when the child rests, replace some nighttime feedings with a bottle so that someone can help you. Don't sleep with the baby in bed, especially if you have nocturnal seizures. Feeding, make sure you're sitting and the baby is supported. You change the baby in a safe place. Usually this can be on a portable changing pad on the floor, and do not bathe the baby alone. If you have any seizures with alteration of awareness, you need to be, if you're going to be bathing the baby, it needs to be someone else there, because if you were to have a seizure, it only takes a couple seconds and the baby could slip under the water. Additional safety discussion points. So a lot of patients will say, what happens if I have a seizure while I'm holding the baby? And the most important thing is to have a plan if a seizure occurs. So, start with a home safety assessment. So set up a safe place in each room of your house where you can place the baby if you have a warning before the seizure or you feel unsafe, so that the baby can be put somewhere and make sure they're safe if you feel something coming on. If you do not fall during seizures, you may want to use like a cloth or a front baby carrier whenever you're walking or standing. But if you fall, then this is not advised. The other thing to talk about for postpartum is postpartum depression. And about 15 to 35% of women with epilepsy will have depression from second trimester all the way to 6 months postpartum, compared to 10% of controls. So it's thought that women with epilepsy are at an increased risk of developing postpartum depression, especially if they had a mood disorder prior to pregnancy. So the risk is highest in women with high seizure frequency, multiple seizure medications, and as I said, pre-existing mood disorders and or patients with unplanned pregnancies. But treatment is available, and it's important to let both your OB and your provider, your neurology provider, know. So you'll probably have just a couple more minutes and then we'll open it up for the last 15 to 20 minutes for questions. But now I just kind of want to take epilepsy through the lifespan and just focus on menopause and bone health. So during perimenopause, there are fluctuations in ovarian steroid levels that may worsen or diminish seizures. So every patient is different. And then during menopause, seizures may improve. And so improvement is usually seen in patients where they had a catamedial pattern and we knew that estrogen worsened their seizures. So during menopause, when you have lower estrogen, their seizures may improve. However, hormone replacement therapy with unopposed estrogen may worsen menopause. And so usually it's your seizure frequency is unchanged, but there are patients who could have worsened seizures or patients who have improved seizures. And this again shows you that, for the most part, usually the seizure frequency does not change. So epilepsy and bone health. Women with epilepsy have double the risk of bone fractures relative to women without epilepsy. And this is really related to the fact that they could have seizure-related trauma. They may have underlying neuro disorders that affect their strength, their gait, their mobility. You may have poor balance related to some of the medications you're on. And also some of these medications can cause osteoporosis. And so we've been talking about those drugs that speed up the metabolism of other things in the body. And so there are some drugs that do this as well. So anti-epileptic drugs that basically lead to vitamin D deficiency. And so, And so what happens is these drugs increase the metabolism in the liver of vitamin D. And so the body has less vitamin D, or the vitamin D is cleared quicker. And the problem is that you need vitamin D to absorb calcium from your intestines and into your bones to maintain strong bones. And those drugs that are associated with vitamin D deficiency are carbamazepine, as we mentioned, as an inducer, phenytoin or dilantin, phenobarb, primidone, topamax at certain doses, oxcarbazepine, and valproic acid or Depo. So what can we do? Well, your provider can check vitamin D levels. And if the vitamin D is low, we typically will make recommendations for supplementations. And I'll just kind of show you our recommendations briefly so you have an idea. But usually we'll put people on about 2,000 international units a day. However, if you have a patient or you yourself, patients for over 50 years of age who've been on drugs that are known to lower vitamin D, but haven't necessarily even been on vitamin D supplementation, or even if they have, you're going to want to get a DEXA scan, which is a bone density scan, to make sure that the bone density isn't decreasing. And if it is, then we want to get you to a specialist so that you can potentially be put on something that halts the reduction in bone density and possibly reverses it. So this is just an example. Again, this is not something that you necessarily need to know, but I just wanted to give you an idea of, ideally we want women to have vitamin D levels over 30. And if it's not over 30, then we have an algorithm of how we would put you on vitamin D supplement to try to protect you. And then a couple months later, we would check your vitamin D level and make sure that it's increasing. So kind of to bring everything to conclusions, there's certain things that we as providers must have conversations about with you as the patient. The one is your menstrual history, contraception planning, postpartum safety and incidence of depression, bone health. I mentioned also sexuality, any sexual dysfunction. A lot of times patients don't feel comfortable bringing up, and so we as providers really do need to bring that up and ask about it. For pregnancy, most women with epilepsy who become pregnant will have healthy pregnancies and healthy babies. And we encourage good care both before and during pregnancy, which is key, and also after, with checking with postpartum depression and figuring out plans for reduction in sleep deprivation, and also if you were to have a seizure. And then lastly, supplementation is important both for bearing age, being on folic acid to help prevent against congenital malformation development, and also vitamin D for all ages. So here are the resources that I said that I would list and that we can provide as well. And I want to thank you for your attention, and then also just remind you that this is something that's done yearly. This is the first year that it was a WebEx and interactive, but next year, hopefully it will be in person, November 8th, 9th, and 10th of 2021 will be Epilepsy Awareness Day, ideally held at Disneyland Resort. So with that, I see that there are some questions, or at least another question that I'll bring up, and then if people want to unmute and ask questions as well. So this is another question but from Melissa, and it says, I'd like to start a family in 2 years, but I'm taking Vimpat, Fycompa, and Onfi. I hope to decrease doses by that time, but I'm scared that I'm not fertile. I am taking folic acid 1 milligram. Do you recommend taking a hormone fertility test? So what I would say is I actually have a lot of patients who went through IVF. So I had many patients that tried to get pregnant and actually did have some issues, especially patients that may have been on Depakote, may not be on Depakote now, but were on Depakote at some point in their lives. Depakote can cause something called PCOS, or polycystic ovarian syndrome, polycystic kidney ovarian syndrome, but PCOS. And what that can do is that actually can increase infertility issues or problems. And so I don't think it hurts to, potentially see a reproductive endocrinologist. especially if you are concerned that about your fertility and get levels checked now. The other thing is that it's not always, there could be issues on the female and male side. And so most men on anti-seizure medications, it does not necessarily affect them, but even if men are, do not have epilepsy and are not on anti-seizure medications, some men can have low sperm counts too. So usually it's important for you and your partner to get tested. Vimpat, Fycompa, and Onfi. So both Fycompa and Onfi can have some inducing properties, which means that you definitely want to make sure that you're on folic acid. So taking 1 milligram of folic acid right now is good. As I said, that's what I put everyone on. And typically I usually keep patients on the medications that you're on 1 milligram, although you are on 3. So it would be a discussion. There's no harm in being on 4 milligrams of folic acid. And so given that we know that Fycompa and Onfi do have a little bit of induction properties, not as much as the other older drugs. But it's something that I definitely recommend. Probably the very first step would be to see a high-risk OB now and talk about pregnancy planning. And they can, test some hormone levels as well, and potentially put you in touch with someone that they work closely with infertility if you want to at least get tested for that. I think if you're thinking about starting a family in a couple of years, that it's never too soon to really start thinking about it, especially if you do find that there's low hormone levels. It's something that you might want to actively plan for, and or try spontaneously if you haven't yet already, for a certain period of time, and then really have a game plan of when you would go potentially see an infertility specialist. I know that was a lot. I don't know if that answered all your questions, but. So what other questions do people have? Or anything that I can clarify? I know it's a lot of information, and I try to cover as much as I can, just kind of on the whole spectrum, but usually questions about pregnancy are the most frequent. So that's why I make that a large part of the talk. So I think that, one of the most important things I think is that, this can be a time of uncertainty, and to really remember that, as I said, many women with epilepsy have the same, ability to get pregnant and timing for pregnancy and outcomes as women without epilepsy. And that really it's about having the conversation. And again, having the conversation early, especially if, you're on multiple medications and you do hope to maybe, reduce it from 3 to 2 or something like that, or get on some that may have lower risk. And so it's never too soon to start the conversation, as I said. So I can stop sharing. I'll at least do that, and then I'll keep the chat box open for a couple more minutes to see if anyone else has any other questions. So another question just came in. Are there any other vitamins that I recommend? And so I mean, the biggest one is folic acid, because that's been shown, and I assume you mean kind of in pregnancy. But folic acid is the one that has really been shown to help improve IQ and help lower chance of congenital malformations. So there's not, as far as in pregnancy, there's not any other vitamins that I would recommend. And then, you know, vitamin D in general. I mean, I find I check vitamin D probably on all of my patients, even the patients who aren't necessarily on those inducing medications. So I find that a lot of people have lower vitamin D than they realize. And the only way you really get vitamin D outside of taking an oral supplement is from the sun. So if you're not out in the sun a lot or not in an area that necessarily you get a lot of sun, or you're working inside a lot, it's also something that you usually want to get checked just to make sure. And a lot of people, even those without epilepsy, take vitamin D, especially if you have a history, you know, in your family of someone who has osteoporosis. It's, you know, good to kind of get started early so that you can kind of prevent that lessening of bone density. Well, if there's not any more questions, I'll give you guys a couple minutes before your next talk. But if it turns out that you think of questions, definitely, you know, the epilepsy awareness team know how to get in touch with me and can kind of share that with me. Oh, there's another one. Okay, so I can kind of talk to the organizers about the PowerPoint and resources as well, that can kind of help with a lot of this. So we can kind of follow up with that as well.